Hi everyone, I'm Cass and this is the Mind Your Being podcast, a space where we'll explore health and what it really means to care for our whole being, our physical, mental and emotional health. Each episode you'll hear from leading health and wellness experts or everyday people who share powerful insights and lived experience. And sometimes it'll be just me, sharing thoughts, tools and reflections from my own journey. More than anything, I want you to feel supported, encouraged and empowered to make informed health choices that feel right for you. If this sounds good to you, please enjoy. My guest today is Dr Lisa Cochrane from WellFemme, an organisation providing women's health services online through telehealth all around Australia. Lisa has kindly agreed to come on the podcast today to help us learn all things menopause, an area of health that is sometimes just as confusing to doctors as it is to those of us experiencing it. Welcome, Lisa, and thank you so much for doing this.
Thanks so much for having me, Cass. It's great to be here.
How about to start off, could you just tell us a bit about yourself and what led you to focus on women's health?
Sure. So I am an Australian trained GP. I went to uni in Melbourne and did most of my training there. And actually, I started my GP career, this was about 15 years ago. I actually started in men's health. and about 10 years ago, I moved up here to the Sunshine Coast in Queensland, and I started working with a couple of other female GPs who had a special interest in women's health, and in particular, menopause, and in particular, hormone replacement therapy or menopause hormonal therapy, which we call it now. And I learned a lot from them, and it became something that I was really interested in. We had a lot of women who were interested in finding a doctor who had a special interest in that area. So yeah, it just really went from there. So yeah, now I've been practicing up here on the sunny coast for 10 years or so, and I've actually recently just opened my own one-woman practice, and I focus particularly on women's health and lifestyle medicine, which is another area of interest of mine.
And do you appreciate the warmer weather up on the Sunshine Coast?
I absolutely love it here. I keep trying to convince all my friends from Melbourne to move up, and I can't understand why they're still there. But it's a great lifestyle. I really enjoy it.
Okay, so menopause is something that affects half the population, yet it's still surrounded by so much stigma and a real lack of knowledge. Why do you think it's been such a neglected topic in public health conversations until recently?
It's a great question, and I think there's a lot of reasons for why this situation has happened. I think it speaks to the broader issue of women's health in general, not specifically around menopause, but just women's health in general, really not ever having been a particular priority. So historically, if we're looking at medical studies that have been done, and whether that's on new medications, looking at disease incidents, they've predominantly been researched on men. And I think because we haven't had a lot of that research really just specifically on women's issues, the dialogue hasn't been there. We haven't had women's health issues in the media nearly as much. The funding is far, far less for women's health research. So yeah, the conversations just don't happen. And I think that that's really played into women's health just not really being a priority, unfortunately. Having said that, things are slowly changing. I think the dialogue around menopause has really got some traction now. There's a few celebrities on board who are writing books about menopause. So I think the conversations are starting, and reassuringly, the medical research is actually starting as well. So hopefully it's going to be something that we learn more and more about, and we need to, because there's not nearly enough information at the moment.
I was surprised to learn that in the last few years, that until recent times, all the medical research, was done on men. So a lot of what gets applied to everyone's health is based on men. And I've heard other people say women are not small men. So I know for myself and amongst my friends, there's been a lack of understanding about the transition to menopause, including perimenopause and then post-menopause. Can you explain the different stages of the transition and what's happening in our bodies at these times?
Absolutely. You're right. There is a lot of confusion around this area. And I think even amongst doctors, there can be quite a bit of confusion around how we talk about the stages of perimenopause and menopause. So perimenopause is the stage where our ovaries are still producing some estrogen. A lot of women are still having regular cycles, but it's the time when our ovaries are starting to wind up. They're starting to move from that fertile stage to the menopause stage. And it's a time of really significant hormonal flux. So it's not one thing, it can be different from day to day. But mostly it's characterized by hormones going up and down wildly, which is what most perimenopausal women will describe how they feel. It can start quite early. So it can start for some women in the late 30s, sometimes the early 40s, and can actually go on for quite a number of years. And that's where sometimes there can be some confusion. A lot of women are told, well, you're too young for menopause. And that's because there is this very long transition period, and which is different for all women. So perimenopause typically will have slightly different symptoms compared with menopause itself. So that's perimenopause. Hormones are all over the place. Periods are often, sometimes they start out looking quite normal, but then they themselves can be all over the place. Really different for every woman. Sometimes it can be that the periods become heavier, so still regular but heavier. For some women, they can become quite spaced apart. For other women, they can come closer together and just be very erratic. Then we move towards menopause. So menopause itself is actually one day. It's really just a definition more than anything else. So that's menopause we describe as being 12 months from your last menstrual period. So if you haven't had a period for a year, on that day you are menopausal. And then for the rest of your life after that, you are postmenopausal. So a lot of women describe going through menopause as if there's sort of this tunnel that you emerge from, but realistically, you are postmenopausal forever. That doesn't mean your menopause symptoms will last forever. Thankfully, they generally will go away at a certain point.
Thank you. That's a very comprehensive explanation. And I think a lot of women listening might find it surprising to know that, yeah, menopause is just marked as one day in the calendar and then it's post-menopause. It's really
Absolutely.
confusing, isn't it? Until you get to it, I think, and start learning more about it.
Women are also told that menopause needs to be at a certain age, that they need to be a certain age to be going through one experience or another experience. And I think that's very unfair. We're not all the same. We all have different genetics and different backgrounds. So, I mean, statistically, menopause will happen around the age of 51, but there's a huge amount of variability there. So, whatever your symptoms are, don't feel that it's not valid to have a conversation around whether or not it could be perimenopause or menopause, because you are not a statistic. You're going to be an individual, and it requires a bit of a conversation about what you're experiencing and whether that might fit into that perimenopause or menopause category.
So most people have heard about the symptoms of the hot flushes and the awful night sweats, but there are so many other symptoms that come with menopause. Acknowledging that each woman's experience will be different, can you walk us through the range of symptoms we might experience during this time?
Absolutely. So if we start at perimenopause, it can be very difficult sometimes to tease out what symptoms are perimenopause and what are symptoms that are just commonly experienced by women in that age bracket. I think women are often dismissed because they say approach their GP with a cluster of symptoms that don't include those vasomotor symptoms, so your hot flushes and night sweats. But actually, those classic menopause symptoms often happen a bit later. So they're often not the first thing that women experience when they're starting to go through that perimenopausal phase. More commonly, it's the brain changes that happen first. So menopause or perimenopause is a little bit like going into puberty. It's that sort of really significant stage of restructuring the brain. And a lot of women will experience things like brain fog, forgetfulness, anxiety. That's a really big one. So there's a lot of women who say, I've been very relaxed for the whole of my life. And then all of a sudden, I just started to feel anxious for no reason. And that's a really, really common one. Mood changes as well. So having an unexplained low mood that was not something that's characteristic for you is another really common thing that we see in perimenopause. In terms of the physical symptoms, often women will notice that there can be a lot of variability in physical symptoms in perimenopause. So a lot of women will have mild hot flushes and they come and go, and that can be confusing. But it's because there is a wild fluctuation in estrogen. So one week you may have really low estrogen. If we did a blood test, it might look like you're postmenopausal, but then the next week you might have a surge of estrogen and you might, on a blood test look like you're 25. So it's very unpredictable, and that makes the pattern of symptoms quite unpredictable as well. But I'd say fatigue, anxiety, brain fog, sometimes noticing some new hairs on your chinny chin chin. That's another common one as well. A few new dark hairs to contend with. And often a loss of libido or a change in the libido as well. They can be some early symptoms. Then as the estrogen starts to drop lower and we head more into that menopause transition, particularly if you haven't had a period for a while, that's often when the hot flushes and the night sweats tend to start. I think in the perimenopause, women often do describe poor sleep. So not so much trouble getting to sleep, but frequent waking during sleep. And then often, unfortunately, those sleep issues can continue through the menopausal transition, where they're woken up in the middle of the night more by hot flushes and night sweats rather than for no apparent reason. So the other thing or the other symptom that tends to become more prominent towards menopause is what we call the genitourinary symptoms of menopause. So that's particularly vaginal dryness, which can lead to painful sex, urinary frequency, urinary urgency, and sometimes recurrent urinary tract infections as well. That becomes much more common. So the symptoms between perimenopause into menopause do tend to be a little bit different. And women often, well, again, statistically, women can experience symptoms often for 7 or 8 years. That would be typical. Some women can experience symptoms for over 10 years. So it's very variable, but it doesn't tend to go away very quickly, unfortunately.
It's the gift that keeps giving, isn't it?
That's right.
So I didn't become aware until after reaching menopause that the estrogen drops off a cliff and that all the changes going on can have such a significant and long-term impact on our overall health. How can menopause affect other key areas of our health, and how significant can the impact be?
It's a great question, because estrogen we often think about as being just a reproductive hormone, but actually it has such a beneficial effect on so many other parts of our body and our brain. So estrogen is absolutely crucial for bone density. We find that osteopenia, which is early version of osteoporosis, and osteoporosis itself really skyrockets through perimenopause and menopause, and almost all women will certainly lose some of their bone density. And really estrogen is one of the most potent factors in that. And now, actually, in Australia, it's quite reasonable to use estrogen as a standalone treatment to prevent osteopenia and osteoporosis in women at risk. And so that's something that I think is perhaps not talked about, is often a surprise to women, is that we can use estrogen to, even if you have no other menopausal or perimenopausal symptoms, we can use it just for bone protection. And that's a very legitimate reason for using it. In terms of other parts of the body, estrogen is really important for our heart health, so our cardiovascular health. We definitely know that after menopause, women have a much, much, much higher incidence of heart attack and stroke, and that estrogen's quite protective for that whole cardiovascular system. The jury's out. I don't think there's enough research at this stage to be able to say, well, we should use menopausal hormone therapy to treat women just on the basis of cardiovascular risk. But it will be interesting to see what happens in sort of coming years around what we do and how we use estrogen to benefit our heart health. But certainly it's very protective for the heart. It is very protective for the brain as well. So there's more research ongoing at the moment looking at the interplay between low estrogen after menopause and dementia. So in Australia at the moment, dementia is now the number one cause of death for women. It's just taken over from heart disease. And there does seem to be there is an impact from menopause on the risk of dementia later on. Again, it's not causal. There's lots of other factors that come into dementia risk, but it's certainly a conversation that's worth having and thinking about. Again, estrogen has a really important role to play, I suppose, with our libido, with our genitourinary system, as we said, and certainly finding that women are really suffering through a lot of unpleasant urinary symptoms after menopause that often they don't attribute to being a menopause symptom that could be treated with hormonal therapies. So that's definitely another area I think to have more conversations about with women.
I think because the conversation is changing and slowly, I think this generation of women are becoming more open to talking about it. We're learning more about those significant aspects. And I think in the past, maybe people thought, oh, you just go through menopause and then you're done and then it's smooth sailing. But it's really going to affect our health in all areas for the rest of our lives. So, we really need to be having the conversations with our medical professionals about all of the symptoms and what's the best treatment to help us live a good life.
That's right. And I think the other thing that we don't think about as much is around this time of perimenopause and menopause is a great opportunity to reflect on all the other things that we're doing in our lives that have a really huge impact on our long-term health as well. So if I'm speaking with women about hormone therapy, I think it's also a great opportunity to talk about exercise, nutrition, stress levels, social connection, whether or not they're using any sort of alcohol or smoking. So really a holistic picture, because yes, menopausal hormone therapy is very helpful and very protective, but it's not the only thing. And I think it needs to be part of a more holistic conversation around the other parts of our life that we have an impact on and that we can modify, and how they will also go on to affect our long-term health.
So now I think it would be helpful for us to discuss potential treatment options available to help with the many symptoms of menopause. Let's start with hormone therapy, and then we can talk about other options that are available as well. So hormone replacement therapy, previously known as HRT, which is now MHT, has had a bit of a rollercoaster reputation over the years, since around 2002, with some really bad press. Could you give us a bit of a background overview on how hormone therapy came to be demonized in a way, and then a bit of an understanding of where the medical profession stands now in terms of what the science says about the safety and the benefits of hormone therapy today?
Sure. So, as you said, hormone replacement therapy, or HRT, is now called menopausal hormone therapy, or MHT, just to confuse everyone. So about, as you said, sort of 20 or 25 years ago, thereabouts, the Women's Health Initiative was published. So that was a very, very big study that looked at the effects of MHT on women and on symptoms. And it came to some conclusions that really scared women and really scared the medical profession, and it completely changed the environment and the conversation around hormone therapy for women. So it particularly indicated that hormone therapy put women at very high risk of breast cancer, that perhaps it may have cause or certainly worsen any sort of cardiovascular disease, and that there was more risk than benefit associated with it. And at that stage, unfortunately, a lot of women who were quite happily using it were taken off it, and there was a lot of fear mongering. So that fear around MHT has persisted for a very long time, despite a lot of new research, and despite a lot of I suppose, the misconceptions around the quality of that research now being debunked. But essentially, the Women's Health Initiative took a huge number of women who were generally a number of years past menopause already. They didn't group those women into women who already had pre-existing heart disease. And so a lot of women who did have significant pre-existing heart disease were then enrolled in the study and were starting to take hormone therapy, which is a problem. They also used a very different type of estrogen and progesterone to what we would typically use now. So that study was done based on something called a conjugated equine estrogen, which is a synthetic estrogen, and also a synthetic progestogen. So that's quite different to progesterone. And those treatments, they do still exist, but they're very, very, very infrequently used because they do increase the risk of breast cancer. Now the environment's very, very different. So we know that if we treat the right women at the right time with the right menopausal hormone therapy, women do very, very well in terms of symptoms and have very, very few unwanted side effects, and certainly very few dangerous, concerning side effects like cancers or heart disease. So I can walk through for a few of those issues. Now we would err on the side of starting with bioidentical or body identical hormones. So our bodies naturally produce estradiol and progesterone, and we now have those available on the PBS to use as menopausal hormone therapy. And they're fantastic because they're very, very low in risk. So they very minimally increase the risk of breast cancer, very, very minimally. And there's very little risk of any other significant complications, in particular, basically no risk of increased clots, which is another one of the issues that came up in the Women's Health Initiative. So the risk profile is much, 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 much safer than we previously imagined. I think, to put it in perspective, for women who are using bioidentical menopausal hormone therapy, the risks associated with that are far, far less than probably the risks associated with not being on it in the longer term, if we're thinking about things like bone density, heart disease, but also just quality of life, because really that's why we use the hormone therapy. So we feel better, we can go to work, we can get up in the morning, we can have a good night's sleep. I think that's really important to talk about the quality of life. It's not just about the risks, it's about the benefits as well. The other thing to mention would be there are some women who are not able to take, so if I talk about the bioidentical estrogen, that is generally applied to the skin. So it comes as a gel or a patch. It's really evenly absorbed. So women tend to have a lot of benefit in terms of having very steady symptom control. And there are a lot of women who previously weren't able to use MHT because they suffer from migraine, or women who live with obesity or who are smokers. They're really not good candidates to have an oral MHT. Whereas now we've got these bioidentical topical MHT options or estrogen options, and that really widens the number of women who are able to use them without any increase in risk.
I was going to say we wouldn't be able to cover off on every possible option with the MHT, but you mentioned the patches and the gels, and then there's also oral estrogen, progesterone. Could you perhaps give us an overview of what's available and how you help women figure out what's right for them, and the important point about when you need to be taking progesterone with the estrogen?
Absolutely. So, in terms of what's available on the market now, it's important to look at estrogen and progesterone separately. We do often need to separate them out, and I can certainly go into why that is. But if we take estrogen, then we've got now these topical estradiol gels. They're used by basically all women. The only women who absolutely can't use any menopausal hormonal therapy are women who have or have had breast cancer. So for everyone else, it warrants a discussion because you may well be a candidate. The patches, they come as either estrogen patches, or you can have combined estrogen and progesterone patches. At the moment in Australia, we're having a bit of an issue, a supply issue actually, with the patches. And so I'm not prescribing them at the moment because most women actually can't get them at the pharmacy. And it looks like that situation is probably going to continue for about another 12 to 18 months, although no one really knows. And it's been a problem for already a couple of years now. So unfortunately, women who have been on patches now often are transitioning to other options just because the patches aren't available. So yeah, they're not in pharmacies, not because there's a problem with them, but just because it's a logistical supply issue rather than anything else. Then if we're talking about that's it, so they're the body identical estrogens that are topical. We've only got one body identical progesterone, which comes as an oral capsule. And that's something that's very well tolerated by women, but unfortunately we don't have a topical progesterone at this stage, a topical bioidentical progesterone. So we talked, or you mentioned a bit about needing to differentiate who needs estrogen and who needs progesterone. Our bodies make both of them and they need to be in balance. But for women who have had a hysterectomy, they don't generally need progesterone, although some women can benefit from having the progesterone from a symptom perspective, but they don't need it. So they can use estrogen as a standalone treatment. For women who have a uterus, then we always need to balance estrogen and progesterone. So progesterone protects the lining of the uterus and stops it from building up and getting too thick, which happens under the influence of estrogen. And we need to make sure we give women enough progesterone so that they're not bleeding. The consequence of not having enough progesterone or just using estrogen for women who have a uterus could be endometrial cancer if we don't protect the uterus sufficiently. But we certainly know that with the standard doses of progesterone, that does a great job of protecting the uterus, and that risk of endometrial cancer is very, very, very low. So then I know you asked about the oral as well. And look, I don't want to dismiss oral estrogens and progesterones. So some women will find that the bioidentical treatment is perhaps not strong enough or not quite right for them. And so if that doesn't work for them and they don't have any risk factors that might cause issues for them taking oral estrogens and progesterones that are synthetic, then that's definitely a conversation to have with the GP, because they can be very, very, very useful for a lot of women. So I don't want to demonize oral tablet, but we wouldn't often start there just because they do have that higher risk of breast cancer and clotting.
What about in perimenopause when the hormones are still wildly fluctuating? Are there any hormones that can be used then, any MHT, or do you have to wait until you pass that 1 day of menopause?
It's a great question, and you definitely don't need to wait. So, commonly, we would use actually very similar treatment regimes for perimenopause compared with menopause. So, women who are in perimenopause, even women who are having regular cycles, can still use the bioidentical estrogen and progesterone. And that can be very, very helpful. It's really important to know that it's not contraceptive. So, a lot of women, if you're having a regular cycle, you're in your 30s or 40s, you can still fall pregnant even though you're in perimenopause. Even if you haven't had a period for 6 months and you're pushing 50, you can still fall pregnant. So thinking about contraception is still going to be important, and menopausal hormone therapy is not contraceptive. So that's sometimes where we have a slightly different conversation with women who may be interested in having some options that will both manage their symptoms but also act as a contraceptive. So sometimes we might use a topical estrogen gel combined with, say, a progesterone only contraceptive method like the Mirena IUD, or now there is a progesterone only pill that's available on PBS called Slinda. That's a really good option as well. So we can combine the two of those, but it's very reasonable to start menopausal hormone therapy for your symptoms if they're really affecting your quality of life, and you don't have to have had no period for that to be a really reasonable treatment option.
For people who might not want to take hormone therapy for whatever reason, and as you mentioned, for breast cancer or other cancer survivors, are there other pharmaceutical options that can provide relief for them?
There are, and I think it's important then to think about what symptoms you're treating. When we think about menopausal hormonal therapy, it does a really great job of treating those vasomotor symptoms. So the about 80% of women in perimenopause and menopause will have hot flushes, and about a third of those women will have really severe hot flushes that significantly impact their life. So if we're thinking about how we manage hot flushes for women who can't use menopausal hormonal therapy, then yes, we can use some antidepressants. So in low dose antidepressants, which it's a pity that they have to be called antidepressants, because I think it suggests to women that their symptoms are in their head, which they're absolutely not. It's just that those medications happen to really help hot flushes. It's got nothing to do with mood or your ability to cope with it. They just happen to be helpful. So low dose antidepressant medication can be helpful. There are some other medications, particularly one called gabapentin, that can help with hot flushes. But it's important to know that those medications don't generally help the other symptoms of perimenopause or menopause. And in particular, they really don't do anything for, say, the vaginal dryness or the urinary frequency. And they often don't do much for those foggy brain symptoms either. Certainly, the antidepressants can help with some anxiety and mood changes, but they don't work for all women. So they're a little bit less reliable as far as their effect on symptoms compared with menopausal hormonal therapy. But there's definitely other options out there. The other one to mention is quite a new medication, which is called Veoza. And it's a daily tablet that is non-hormonal, that's specifically to treat hot flushes. And it's a really great one. It can really be life-changing for women who have significant hot flushes but can't have hormonal therapy. So there's more research going on out there, and I think there's more medications out there that are being developed for women who don't want to or aren't able to use hormone therapy.
You mentioned the genitourinary symptoms, and I know that there's the vaginal estrogen, the topical cream that's available to help with those symptoms. Is that suitable for breast cancer survivors as well?
It can be. So it's generally considered to be very safe and have minimal to no increased risk of breast cancer. Some breast cancer surgeons and oncologists are not 100% keen on it. And I think that's perhaps because that research maybe isn't there to be 100% confident that it doesn't have an impact on potential breast cancer risk. But by and large, for most women, it does not increase your background breast cancer risk. And it can be an incredibly useful tool for those genitourinary symptoms. Even if you don't suffer with vaginal dryness, it can be very helpful for urinary frequency, recurrent urinary tract infections, and can just be a lifesaver. And it's important to know you can also use that vaginal estrogen in conjunction with other topical or oral hormonal therapies. So it's not one or the other. It's very safe to use both. And I suppose to put it in perspective, a year's use of vaginal estrogen equates to about one oral estrogen tablet. So in terms of how much is systemically absorbed into your body, it's a very, very, very low dose that's actually absorbed. But yeah, it's great bang for your buck as far as getting rid of those vaginal symptoms, which can make women miserable.
What other lifestyle treatments might you suggest to women struggling with peri and postmenopause?
It's a great question, and I think there needs to be a lot more research done in this area. And again, I think it depends on what symptoms in particular we're talking about. So if we're looking again, particularly at hot flushes, then the other sort of non-pharmacological treatments can be things like meditation and mindfulness, self-hypnosis, and cognitive behavioral therapy. Not because they change the actual occurrence of the hot flushes, but they often help women cope a lot better with living with them. So that's one option. Certainly for women who are smokers or women who are overweight, cutting back or quitting smoking ideally and losing weight is a really, really effective way of treating a lot of the symptoms and in particular the hot flushes. Outside of that, unfortunately, if we're thinking about symptom control, there's not a great amount of evidence for other lifestyle changes. So things like exercise and nutrition are absolutely wonderful, so important, but have not really been shown to have much an effect on a lot of the perimenopausal and menopausal symptoms. So I think it'll be interesting to see what research comes out in this area in the future to see what other things might be helpful. But yeah, at the moment, the lifestyle changes are important for overall health and well-being, for managing your risk of heart disease, for managing your risk of osteoporosis, but specifically for your symptoms of perimenopause and menopause, unfortunately, they don't seem to make a huge difference.
So I think given the lack of information, a lot of women feel really nervous bringing up the conversation to have with menopause or even the hormone therapy with their GP. What advice would you give to someone who wants to start that conversation, but they're not sure really where to start?
It's hard. I see a lot of women who have approached their GP and been told you're too young for perimenopause or menopause, or you just need to wait out the symptoms or they'll get better, and or just do more exercise. So I do feel for women because often they have had an experience of being dismissed, which can really, understandably put you off wanting to seek more help. I think the most important thing is selecting a GP who has an interest in that area. So as GPs, we often, we're good generalists. We know a little bit about a lot, but most of us will have some sort of area of interest. So whether that's going to be menopause or skin cancer or children's health. And I think really looking for a doctor who has a particular interest in menopause care is going to go a long way. In uni, so in medical school, we learn nothing essentially about menopause. And so it's up to us as GPs to really take it on board and do our own education activities and our own upskilling. And that certainly takes time, and other people will invest their upskilling in other areas. So I think finding a doctor who's particularly interested is important. And then I think keeping a really good diary of your symptoms is really important. So even for a week before you come in, maybe making a record of, well, what are my cycles doing? I know a lot of us use apps to keep track of our cycles and what's going on, but having a sense of what's happening with your cycles and how that compares with what they were previously, really writing down any symptom that could possibly be associated with perimenopause and really what you're noticing has changed. For one, I think it helps to reflect on our bodies and what's happening and really gets us more in tuned as to what's happening in terms of our health. But it does provide us as GPs with a lot of great information to be able to give some more nuanced advice about what might be helpful.
I was blown away to learn that in medical training, there's really not anything covering menopause, given that it's going to affect half the population. And like we said before, it has such a significant impact on our health for the rest of our lives. It's just crazy. I read recently on the Australian Menopause Society website, I think it was back in March, the government announced in the 25-26 federal budget some increased spending to train health professionals. So hopefully that extra training is coming. But like you said, it's probably down to which GPs are going to take an interest in that. I think they're looking at public health awareness campaigns and some further research. So that's all positive. In the current climate where we're on social media a lot, I think there's a lot of confusion because sometimes you have a lot of people who might be an influencer or have a profile and they're spruiking a lot of menopause products that haven't necessarily gone through clinical trials to assess the effectiveness. How would you advise your patients on how to sort through all the noise to try and find quality, safe supplements or products if they're going to try something?
It's a pretty confusing time to live in, I've got to say. I find a lot of women who I speak with as patients will find that they're absolutely confused about where to look for reliable information. A lot of information does actually look really reliable and slick, but that doesn't necessarily mean that it's accurate. So at the moment, I tend to find that with the conversation around menopause getting louder, which is a very positive thing, unfortunately, it means that some people have tried to, I think, really jump on the bandwagon and use women's confusion to, I suppose, to market them rubbish that isn't going to work realistically. I think if we look at the supplement market in particular, I mean, a lot of women are very interested in supplements, but unfortunately, the research just isn't there to back up any particular supplement or supplement regime that's been shown to make really any difference to menopause symptoms. So in terms of treating women with supplements, I think there's a good reason to say check women's vitamin D if they've got bone density issues, and make sure we've optimized their vitamin D. So really targeted supplementing is appropriate for a lot of women, but all of the nonsense out there around, I won't name names, but there's all sorts of products on the market that I think really are marketed towards women's vulnerabilities. As medical practitioners, we are not allowed to make claims for outcomes. So I can't say, come and speak to me, I'm the best doctor, I'm definitely going to help cure your menopause. That would get me deregistered pretty quickly. So, but the difference is that people who are not medical professionals can say absolutely anything they want. They can market anything they want, and there's really no repercussions. Interestingly, when it comes to supplements and other things that you'll find online, they're safe in so much as they're able to end up on the shelf because they're safe, but there is no requirement for them to be effective. There's no requirement for them to actually have the outcome that they promise. And that's very different compared with anything that's on prescription. If it has been approved for a particular condition, it needs to have been shown that it will work for that condition. So I think that's sometimes where the waters can be a bit murky, because that voice from medical professionals is not really there because we're regulated. We can't say whatever we want. But the loud voices out there on social media or even just in the popular media that can tell you anything that you want to hear. So you'll buy something, unfortunately, can be really, really loud. So if you're looking for reliable information, I'd stick with organisations that are legally required to give you accurate information. So places like the Australian Menopause Society, Jean Hales is another great reference. And even having a look at the WellFemme website, we've got a lot of good resources there that are accurate. They're based in science. And it can be difficult though. I really do. I mean, even I get sucked into Instagram sometimes. I think, oh gosh, that's going to be amazing. But you just need to take everything with a grain of salt and see what feels right and what's going to be accurate.
As you mentioned, the Australian Menopause Society and the Jean Howes Foundation, they're actually run and the information they put out is informed by trained medical professionals and specialists. And the same with your WellFemme website. I was having a look at that recently. Again, it's informed by medical research. You've got blogs on the website about various topics to do with menopause. You've got a number of different drop down menu items on all the various topics. So it's really a helpful website. Speaking of WellFemme, as we mentioned earlier, you work with WellFemme, which is a telehealth service with consultations available for women all around Australia, specifically for comprehensive menopause support. Can you tell us a bit more about how it works and what kind of support women can expect when they consult with WellFemme?
Sure. As you said, WellFemme is a telehealth only service for women, specifically for menopause care. It was the brainchild of Dr. Kelly Teagle, who just came up with the idea, I think probably back in 2017, around having a service that was 100% online and could be accessible by women all around Australia. So we're really lucky. It's a wonderful place to work in terms of there's a number of other female doctors who work there. I think now we're up to 23 female GPs, and we have a lot, each of us individually has a lot of background and extra education around menopause, but yeah, a lot of the GPs also have other very nuanced interests in other parts of women's health care as well. The benefit of that is that we're all able to connect with each other. So we have a space online where we're able to connect. We can talk through some really difficult cases. We can all give our input. Obviously, it's all de-identified information, but having that brains trust there is so helpful and I think really optimizes patient care. I mean, it's like having 23 different doctors in your pocket for your consultation, because if we don't know or if we need a second opinion, we'll ask one of the other GPs. And yeah, so it's a really great way to practice. For women, it's really easy to access. You do not need a referral from your GP, from anyone. You can just give us a call. So jump online, give us a call and book an appointment. There is a little bit of a wait time at the moment, a few weeks, but once you're in, and we're very happy to manage all of the aspects of your menopause care. One thing we don't do is manage all of your healthcare though. So we can't become your regular GP, but for us, it's really, really important to communicate with your regular GP. So we don't want to sort of treat your menopause in isolation. We want to make sure that we integrate back with your regular GP, with your consent, of course. And so we do send out some pretty extensive notes and information back to each woman to pass on to her GP if she'd like. And we're always happy to speak with GPs, their community GP, if they would like.
I think that's really helpful to know because, as we said before, with the lack of education, a lot of women are going to find that their doctor either doesn't want to have the conversation or they just don't actually have the resources to have the conversation. So women thinking about, well, you may still see your GP that you've seen forever about all your other health issues, but WellFemme is there available telehealth, I think a few weeks is nothing to wait to get that comprehensive menopause support. It's fantastic. And you ladies were ahead of your time before COVID, even with telehealth. So it's
Absolutely. And look, I
awesome.
can't take any credit for that. That's all
Oh,
Dr.
yeah.
Kelly Teagle's hard work, sort of building the business from scratch. I think the other thing for women to know is if they are Medicare card holders, there are Medicare rebates available. And so you don't need to have seen one of the GPs within the past 12 months. So often to get your telehealth Medicare rebate, you need to have had a face-to-face consultation. But because of the Medicare item numbers that we use, we don't actually need to do that. So it is really accessible for absolutely anyone. We do also have a provision for women who are on a concession card or who have a low income to be able to have a concession consultation as well. So if that's the case for you, just certainly mention it when you call up to make an appointment, because we do have some flexibility around that.
I know we were talking earlier, you mentioned some recent changes to the PBS with regard to the pricing of the hormone therapy now. Can you talk a bit more about that?
It's great. So this has only just happened relatively recently, that there's been more funding within the PBS to cover women's health medications. So it used to be that all of the menopausal hormonal therapies were private scripts. In other words, they were quite expensive, and that really made them out of reach for a lot of women. But now there are a number of the more common treatments that we use, and in particular, the bioidentical hormones that are available on the PBS. So that means with a prescription, they're the same price as any other medication. And if you have a concession card, then that's, I think it's $6 or $7 for that concession medication. So it makes such a big difference in terms of accessibility for women to be able to go back month after month and actually pay a reasonable price for their hormonal therapy. So yeah, things are definitely changing in a positive direction, and there are still some other women's health medications that are going to be going onto the PBS ongoing. So I think we're going to see more money in this space, which will be great.
That's great to hear. It's well deserved. So I know this conversation is going to be so helpful for a lot of women today, and also for women in the future who are yet not in the transition of menopause. Is there anything else you'd like to say that we haven't covered today, or that you'd like to share with our audience?
I think a conversation that comes up a lot for me when I speak with women is that the time around that perimenopause or menopause is a fantastic time to stop and reflect on our health and our overall health. So women, we're amazing. We do all the things. Often women in their 40s and 50s, they've been busy for a long time. And I think a lot of us actually haven't really looked up and paid a lot of attention to what's happening in our own bodies, and really thought about what we want and what we need for our own health. So I think it's a great time just to have that conversation about, well, menopausal hormone therapy might be fantastic, but what are the other things that we can do in our life? And that's from a physical, nutritional, spiritual, all sorts of, I suppose, facets of our lives that go along with this transition, because it's not just our hormones that are changing. Actually, there's a lot more in our bodies and our minds and our values that's also changing. So yeah, I think having that broader conversation is really important.
Yeah, I agree. I think we hear a lot about the negative symptoms of menopause and, oh, we're all getting older and whatnot. But as you said, I think it's really can be a time of reset, or look at it as a time of
Mm.
opportunity to look at, well, I've got the rest of my life. What do I need to get in check, and how do I want my quality of life to look going forward? And as you said, a lot of the times women have been doing all the things. Often we neglect our own needs. So it's really forces you, I think, to have that time of reflection and, yeah, consider how you want to move forward.
Yeah, exactly. I think that there's often a big shift in identity, and our mindset around that identity change is really significant. And the more we talk about it, and the more we support each other, and the more we make those conversations public, I think the more that that identity shift can become a really positive thing instead of this feeling that, oh well, we're past menopause. I guess we're sort of being put out to pasture, instead of framing it as, well, this is just a whole new phase of life where we don't need to worry about so many of the things that we were worrying about before, and it's, yeah, really our time to think about ourselves and do what we want.
It can be positive.
Mm.
We've just got to look for those opportunities, I think. As this podcast is called Mind Your Being, could you share with us three personal practices or things that you use to mind your being? It
Oh,
could
that's a good
be an
question.
exercise, a particular food, a practice.
So for me, after I turned 40, I decided to take up surfing. And it's my favorite thing in the whole world. And it just covers off on a whole range of positive things. I get some exercise, I get some sunshine. I can't get any phone calls or messages when I'm out there. And I go out with a couple of girlfriends. And so it's a really nice social occasion. I'm very bad at it, but it still really is something that I enjoy. I think aside from that, I definitely enjoy, I think at the moment, probably this phase where my kids are a little bit older and I'm actually able to spend a lot of time learning. So I'm at the moment I'm studying towards a fellowship in lifestyle medicine. So medicine that's really looking at how we can use lifestyle change to prevent and treat and even reverse chronic disease. So I've always been a big nerd, and now I've got some time back in my life that I can study, and I absolutely love that. That's really stimulating for my brain, so that keeps me happy. And aside from that, I'm a big fan of just spending a lot of time with my family. And yeah, we just spend a lot of time outdoors hanging out with our little dog. And that's definitely a great source of satisfaction for me. So yeah, they're probably the things I do to mind my being.
Thank you. That's wonderful. And do you find with the surfing, you sort of get a mindfulness because you're just in the moment out there?
That would depend. It would depend on
Okay.
whether or not I've thrown myself into a situation that is slightly beyond my
Okay.
ability, in which case, no, there's no mindfulness at all. There's mostly just completely freaking out. But if I pick the right day, then yes, I can absolutely um, get a nice sense of zen. So I'd say it's 50-50.
Okay. So we mentioned your WellFemme website before, so people can find that at wellfemme.com.au, WELLFEMME.com.au. And absolutely, that website is really informative. It's really easy to navigate. As I said, there are blog posts on there on all the various menopause topics, and there's just a wealth of research on there. It's great. Where else can people find more about WellFem online if they're interested?
Yeah, so WellFemme can be found on Facebook and Instagram. On Facebook, there's also a Facebook group for women to support one another. It's called Cheer Squad. So that's a great space to be able to ask your questions and just, find some support from other women who are in the same boat as you. WellFem also has a program called Next Phase Women's Wellness, and that's a really comprehensive online course looking at all of those other lifestyle changes and just general women's well-being around that time of menopause. So that's definitely worthwhile checking out as well. So yeah, but yes, thank you for that. It's a really useful website. I think there's a lot of great information there, and I think it's always really good to be able to connect with other women through things like Facebook or Instagram to get that support if you don't have that around you already.
Yeah, absolutely. It's wonderful. And I'll just mention again that WellFem is available all around Australia in regional and remote areas as well. It's telehealth, and as you can hear today, Lisa is beautiful and very kind.
Oh, thanks.
And Thank you to you and Dr. Kelly for organising this. I think it's been a great conversation. I think it's really going to be helpful for women because, yeah, it can be really confusing and not knowing where to get the right information. So I think it's really going to be great. Thank you again.
No problem. Thanks so much for having me.
Thanks so much for listening to this episode of the Mind Your Being podcast. If you enjoyed it or found it helpful, please follow the show wherever you get your podcasts and share it with a friend who might enjoy it too. If you have a moment, please leave a quick review. It really helps others discover the podcast. Thanks again for being here. Take care, and until next time, mind your being.